Hello everybody, this is Dr. Podell. Today we will be talking about intravenous fluid management in inpatient setting. The learning objective for today includes briefly discussing hemostatic mechanism involved in the water balance. Then we'll be describing and differentiating different kind of colloid and crystalloid IV fluid. Then we'll be talking about preferred IV fluid in different inpatient settings, including vomiting, diarrhea, sickle cell disease, and pancreatitis. And then, last but not the least, we'll be talking about fluid management in sepsis and where the evidence has grown over the years. Are we overdoing IV fluid? So we'll be talking about it. Before talking about how much to give, we need to know that how much we have inside our body. So as you can see in the slide, average amount of fluid that a male adult contains inside the body is around 60%. If you look at the slide, infant, they tend to have more water, which is 10% more, around 70%. On the other hand, female, they have less amount of water because they have relatively more amount of fat in their body, around 10% of essential fat inside their body. Let's talk about where does that 60% of water belong inside the body. So total body water, as we talk about, 60% out of that, 2/3 is inside the cell and 1/3 outside the cell. And that extracellular fluid is divided into extravascular, which is 3/4, and intravascular, which is 1/4. And there is some amount of transcellular fluid as well. Let's briefly talk about hemostatic mechanism affecting the water balance. There are mainly two systems I would like to talk about: renin-angiotensin system and antidiuretic hormone. So the renin-angiotensin system is activated when there is a dehydration or decreased renal perfusion. So what happens? The renin will be synthesized in such condition. So renin, what does it do? It results in ultimate secretion of aldosterone, and which does everything to absorb sodium and water. If all the sodium is absorbed, what is going to happen to the urine? Urine will be left with very little amount of sodium, which is less than 20. On the other hand, if you have excessive antidiuretic hormone, it results in opening of that aquaporin, which results in absorption of all the water. That absorption of the water results in expansion of the vascular volume and results in increased perfusion to the kidneys, which results in inhibition of that renin-angiotensin system. So when renin-angiotensin system is inhibited, it results in inhibition of aldosterone, so there won't be sodium absorption. So this urine is going to be left with high amount of sodium. So that's the difference between activation of antidiuretic hormone and activation of renin-angiotensin system. Let's talk about different kind of IV fluid. The first one is a D5 water. It is isotonic to start with, but once it goes inside the body, liver metabolizes all the dextrose, and whatever is left is just the free water. And this is typically used to treat hypernatremia, who tend to have a water deficit. So you calculate that free water deficit and you replenish that free water deficit with that D5 water. Then there are crystalloid, which are the fluid containing different concentration of electrolytes. Then there are colloids, so which contains crystalloid along with some large protein molecules. The size of those molecules are bigger than the size of capillary pores, which is 65 kilodalton. So which results in inability of this protein to permeate through the capillary pore. So they are retained inside the vascular compartment. So they tend to stay inside the vascular bed. So let's see what is going to happen when you are resuscitating somebody with a D5 water. So let's say you are going to give 1 liter of D5 water. So let's see what is going to happen. So you give 1 liter, it goes to intravascular, goes to extravascular, extracellular, intracellular. So it goes everywhere. So when you are giving 1 liter of D5 water, as you can see here, this 83 ml, 83 cc is going to stay inside the vascular compartment, which is clinically very, very important. So if you're treating somebody with hypernatremia with a D5 water, you should not really worry too much about volume overload, because only 83 milliliter is going to stay inside the vascular compartment. It's very important to remember when you are treating somebody. So let's talk about crystalloid advantages and disadvantages. Crystalloid tends to replete both intracellular and extracellular compartments. So it's good for a dehydrated patient, which is unlike colloid, which tends to just stay inside the vascular compartment. You cannot give colloid to treat dehydration. On the other hand, it is also good for maintenance fluid. It tends to have less side effect. Remember, bigger the molecular size comes with the bigger antigenicity, the high incidence of allergic reaction. So colloid tends to have a higher incidence of allergic reaction and coagulopathy. But the drawback of crystalloid tends to be you need to give 3 times more, because they tend to redistribute that fluid in different compartments. So let's say somebody has a blood loss of, let's say, 1.2 liter during surgery. You can give 1.2 liter of colloid to replenish. But if you're just giving with the crystalloid alone, you need to give 3 times more, which is going to be 3,600. So to decrease the amount of volume infused, you tend to give some amount of that blood loss with colloid, which is going to decrease the amount of total volume infused to the patient. So that is a beauty of colloid. You can decrease the amount of volume infused to replenish the volume lost. Let's talk about colloid. These are essentially crystalloid solution, but with the macromolecules, which have size more than 65 kilodalton. So they are going to stay inside the vascular compartment. So these are ideally used when crystalloid replacement exceeds larger volume, somewhere around 3 to 4 liter, because replenishing that amount of blood loss with just the crystalloid is virtually impossible. So drawback is higher cost, and they also tend to have a higher side effect like allergic reaction and coagulopathy. Let's talk about albumin. The size of albumin is 67 kilodalton. So it is classically used for correction of hypoalbuminemia, and also for hypovolemia and for resuscitation of early septic people, because it has been shown to preserve glycocalyx and renal function in critically ill patient. So surviving sepsis campaign recommends consideration of albumin addition to crystalloid for initial volume resuscitation in patient requiring substantial amount of crystalloid. Let's talk about hydroxyethyl esters, hetastars, pentastars, and tetrastars. So these are no longer used for sepsis because they have been associated with the coagulopathy and acute kidney injury, but they are still employed for resuscitation during surgery, specifically replenishing the blood loss during major surgery. Apart from that, we are going away from use of this agent for sepsis management because there is increased risk of acute kidney injury and increased risk of death compared to crystalloid in a septic patient. So let's talk a little bit about duration of volume expansion. As you can see in this slide, duration of volume expansion is 1 to 4 hours for crystalloid, including normal saline and ringer lactate. So what does that mean? By 4 hours, whatever volume you give is going to be distributed all around the body. So the duration of volume expansion is going to be a little bit longer for albumin. As you can see here, it is around 12 to 24 hours. So let's say your patient had a paracentesis today at 8 a.m. and got 25 grams of albumin. So their maximal volume expansion starts around 12 hours, which is 8 p.m., and then continues until 24 hours, which is 8 a.m. And most of that time frame, you are going to be at your home. So somebody who is covering your patients should have a written sign out that your patient is likely to get that volume expansion during that particular time frame, and have a clear instruction in terms of what needs to be done to address that volume excess during that time period, and which is typically use of loop diuretic. But the covering person should have a clear instruction in their sign out, so make sure to write that in your sign out if your patient got elbow. Other distinct advantage to using colloid to resuscitate the patient. So this was a long time debate, but it was not shown to improve the outcomes. So they did this study called Crystal, which included a good number of patients, almost 1,500 people in both arm, both colloid arm and crystalloid arm. It was done in 57 ICUs in Europe and Africa, and what they looked at was 28 days all-cause mortality, and then there were secondary endpoint which included mortality at 90 days. So what they found, as you can see here, there was no statistically significant difference in mortality. But in terms of 90 days, there was a statistically significant mortality benefit with a colloid, but author concluded that it was exploratory finding and it should be confirmed with future studies. So in critically ill patient with hypovolemic shock, fluid therapy with colloid did not change 28-day mortality, and but it was associated with more day alive, free of vasopressors, more day alive and free of mechanical ventilation, and fewer death at 90 days. Um, so so this was kind of a game changer. Before this study, we used to use a lot of colloid, but it actually opened our eyes. It changed our practice. We went away from using too much colloid at that point. So the current use of colloid is mainly for the intraoperative volume replenishment and for the correction of hypoalbuminemia that is short term, especially in the people who are third spacing. And then it has also proven to have some potential, especially albumin has a potential to prevent or preserve glycocalysis and renal function in a person with early septic shock. So let's see this cartoon to see what is going to happen when you give 1 liter Hedestars or albumin to your patient. So you're giving 1 liter, it goes to intravascular space. Oh wow, look at this. All of the volume, that is 1 liter, is going to stay inside the vascular space. Let's talk about zero point 0.9 normal saline. As you can see here, normal saline has 154 of sodium and 154 of chloride. Sodium a little bit more than normal, not much of a clinical significance, but that excessive chloride of 54 has a clinical significance. What it does, if somebody is getting normal saline, their bicarbonate tends to go down. So chloride, which is a normal, is around 100. So let's say they started around 100, their chloride tends to go up to 102, 104, 106, and their bicarbonate tends to go down, which is 24 to 22, 20, and 18. So you see that trend, and that is called hyperchloremic metabolic acidosis, which is classical of 0.9 normal saline. So in addition to that, the way 0.9 normal saline is stored is packed in polyvinyl chloride bags, which is acidic in nature as well. So because of this acidosis and the recent randomized control trial where there has been increased incidence of acute kidney injury, we are going away from use of 0.9 normal saline as a maintenance fluid. So use of 0.9 normal saline is very specific to some conditions, which include hypovolemic hyponatremia, hypochloremic metabolic alkalosis, classical with vomiting, and then as irrigation. So let's say bladder irrigation or something like vehicle for IV drug use, something like antibiotics. So remember, you have to use 0.9 normal saline with a blood transfusion. You cannot use ringer lactate because ringer lactate has a calcium. Last but not the least, this specific indication of 0.9 normal saline has been validated in so many different randomized control trial. People getting ringer lactate had adverse outcome in most of the randomized control trial, and which is not a surprise because ringer lactate tends to be hypertonic and tends to increase brain swelling, and which is in contrast to 0.9 normal saline, which has a plasma which has a tonicity of 308, which is close or more than plasma tonicity, which is around 280 to 295. So let's talk a little bit about balanced solutions. As you can see here, ringer lactate, ringer acetate, and plasmolide. These are the three, and the classically most commonly used one is ringer lactate. So this valent solution, they have composition closer to that of extracellular fluid. Choice of IV fluid in the modern clinical practice, these are considered the fluid of choice, and they are mainstay of administration in perioperative and critical care setting. So as we just talked, we don't really use this in CNS surgery, GI loss, or somebody who is getting IV antibiotics or blood transfusion. So let's see what is going to happen if you're resuscitating with a normal saline or ringer lactate. So you give 1 liter, as you can see in this carton. So 1/4. See, it went all the way to extracellular fluid, and then finally there will be some equilibrium with intracellular. But when you give, so immediately it goes to up to extracellular fluid. So only 1/4 will remain in the intravascular compartment. So that means if you're giving 1 liter, only 250 cc is going to stay in the vascular compartment. So talking about most commonly used intraoperative crystalloid, as you can see here, ringer lactate. So it has, it's hypotonic. It has less sodium, like 130. So it tends to worsen cerebral edema in people with brain injury. Also contains calcium. So remember, ringer lactate is not something we'd like to give in somebody with a terminal liver disease where there is impairment of synthetic function. So remember, lactate formed in the muscle or anywhere in the body tends to go to liver, and liver metabolizes that to bicarbonate. So for that to happen, you need to have a good liver. So if you have a impaired liver, especially terminal cirrhotic people, they tend to get lactic acidosis, just with the use of ringer lactate. All right, let's talk about a SMART trial. This is one of the trials that changed our practice. It was published in NEJM 2018. The name of the trial, SMART trial. It was about balanced crystalloid versus normal saline in critical ill patient. So question was to determine the effect of isotonic crystalloid composition and clinical outcome of critical ill patient. So it's not only septic people. So remember that. So study was cluster randomized multiple crossover trial, single academic center, 5 ICUs, around 16,000 people, almost 8,000 in balanced crystalloid and almost 8,000 in normal saline group. And then primary outcome was major adverse kidney event at 30 days, death, renal replacement therapy, and persistent renal dysfunction. So as you can see, there was a statistically significant reduction of MAC30 in balanced crystalloid group from 50.4 in saline to 14.3, that's 1.1%. So, so the number looks like a smaller one, but when you look at how many people they get admitted to ICU every year, almost 1 million. So 1.1% of 1 million turns out to be somewhere around 11,000. So use of balanced crystalloid tends to decrease that number of MEC30 in critically um, ill people. So that actually changed our practice. So after this study, we started using balanced crystalloid as a fluid of choice. So then they did a secondary analysis of this SMART trial. So remember, the primary trial was done in a sick people admitted to ICU, but they pulled septic people out of that population. So out of 15,802 patients enrolled in SMART, they um, pulled out 1,641 number of people admitted to ICU with a sepsis or septic shock, and then they did a secondary analysis. What they found, there was statistically significant difference in 30-day in-hospital mortality, less with the balanced crystalloid versus saline, 31%. 31.2 with the normal saline versus 26.3 with 15.7 relative risk reduction and 4.9 absolute risk reduction with normal needed to treat 20. So there was a modest reduction. So 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 clinical take-home message from this secondary analysis trial is use of balanced crystalloid um, um, appears to reduce 30-day in-hospital mortality and adverse kidney event. So as we talked about earlier, number needed to treat was 20 to prevent one death. So given the low risk and plausible, physiological advantage, balanced crystalloid is a default fluid of choice in sepsis resuscitation. And especially when you are going to use large volume um, of fluid and when there is a risk of acute kidney injury. And then some other studies, they have also shown that earlier the fluid, earlier you choose the balanced fluid, better is the outcome. So these are the take-home messages from this secondary analysis. So let's talk about salted trial, balance versus normal saline in non-critically ill. So it was done in the same center, that Vanderbilt University. When they were doing SMART trial in ICU, they were also doing salted trial in the emergency department. So they were looking at outcome in the emergency department. So single center, pragmatic, multiple crossover trial. So comparing balanced crystalloid with a normal saline. So what they did, 13,346. So half of them were in balance, half of them in saline group. So pretty good number actually. So what they found was, so the primary outcome was hospital-free days. So use of crystalloid did not result in shorter time to hospital discharge, which were called hospital-free days, which was the primary outcome. So there was no difference. But in terms of MEC30, it did lower the incidence of secondary outcomes, something like persistent renal dysfunction, death, or dialysis. So like SMART trial, it showed a decreased incidence of acute kidney injury. So let's talk about another really important trial. So this is about outcome at 90 days. So we saw balanced fluid makes a difference in 30 days. So what about 90 days? So they did this study in Brazil, 75 ICUs. They had almost 5,000 plus people in both arms. Primary outcome was 90-day survival. And what they found, there was no statistically significant difference between those two groups. So it was a really important trial, saying that it does not really matter at 90 days. One interesting point I'd like to point out here is if you look at the traumatic brain injury, though, so use of normal saline had a favorable outcome in those subset of people. No, which was not surprising given the composition of normal saline tends to be a little bit hypertonic, tends to help in these people with the traumatic. So let's talk about sepsis and fluid. So talking about sepsis, let's go back to 2001, early goal-directed therapy in treatment of severe sepsis. This is a landmark trial that changed the way we practice medicine. It advised us to use fluid, and fluid makes a difference. Fluid is one of the three things that makes a difference in the sepsis management: early antibiotics, source control, and fluid. So this was the first trial ever to guide us on fluid management. So it is called goal directed because there are so many goals that you are supposed to achieve. So you're supposed to give 30 cc per kg, and then if the lactate is more than 4 in for 6 hours, and then you measure CBP and you keep a map more than 65. If it is less, despite fluid, you give norepi. You give fluid 500 cc 30 minutes until CBP is more than 8. Then is hemoglobin less than 10, you give blood transfusion, and they still CV oxygen, central venous oxygen more than less than 70, you give inotropic. So there are so many goals that you're supposed to meet, and that's why it's called goal-directed therapy. And what it found was at 6 hours, people getting 5 liter versus 3.5 liter of fluid, there was a significant difference, statistically significant difference in mortality, which was 30% versus 46.5%. So almost 16% different in difference in mortality. And then the benefit was attributed to the fluid administration, early fluid administration. As you can see here, those in the standard therapy group, they got 3.5 plus minus 2 in first 6 hours versus early goal director, they got almost 5 liter plus minus 3 liter of fluid. So before I come to other studies, let's talk a little bit about albumin. They did a study on albumin in 2014. They compared between crystalloid versus crystalloid plus 20% albumin. Primary outcome was 28-day mortality. There was no difference in 28-day mortality or secondary outcome. Then there was another study that came in 2019 where they found that the use of albumin is supposed to maintain the glycocalyx, which is messed up in a people with sepsis. So in a sepsis people, after giving fluid, you're supposed to give a dose of albumin before you put them on vasopressors. Then over the time, what happened was after early goal-directed therapy, people became super excited. They started giving ton of fluid, keep on giving for weeks. And what they found was, they started seeing all the side effect complications of excessive fluid challenge. And then they did this study, Process Investigator 2014 in NEJM. So they compared 1341 patient early goal-directed therapy versus protocolized care without CVC, ionotropes of blood versus usual care. So they compare all this, but remember this usual care is completely different than usual care in 2001, where they have not given any fluid, versus here, there is a significant amount of fluid. So that we have to be very clear that some fluid helps, but this usual care is different from the original usual care. what they found was there was no difference in primary outcome of 30-day in hospital mortality and other outcomes. So remember, severe sepsis group were not included in this trial. So this trial actually made the case for CVC, the role of CVC uncertain, the role of RVC uncertain, and role of dovitamin uncertain for sepsis management. So bottom line was targeted fluid resuscitation. Don't overdo it. Then there were two subsequent large randomized control trial done in UK, which is PROMISE, then done in Australia, New Zealand, RISE. So they also look at the similar, they also found the similar finding like PROMISE. As you know, when you do multiple randomized control trial for the same region, people do meta-analysis. So they did a meta-analysis, the PRISM investigator, and what they found, early goal directed treatment versus usual care, it resulted in more ICU, more vasopressor days, higher cost, no benefit at any set. But I would like to show you one thing very, very clear, make it very, very clear here, is in all these studies, if you see, pre-randomization, they got almost 2 to 2.5 liter of fluid. That was pre-randomization. And then in first 6 hours, they got almost 1.5 to 2.3. So they got almost like 3.5 to 4 liter fluid. So the usual care still involves that fluid resuscitation. So that part we should not be overlooking when you are making the inference, when we are taking inference from these studies. So key finding from few important studies I would like to bring here. The first study which was done in ICU and emergency department. It included dynamic fluid assessment using passive leg raise, and what they found was dynamic guided group received fluid and they had less renal or respiratory failure. And then there was another trial, classic trial, where they studied about restrictive fluid management in ICU patient. So the key point there was after initial 1 to 2 liter, keep fluid conservative, avoid overload. Then they did this Clover trial, early restrictive versus liberal fluid management for sepsis-induced hypotension. So that was multi-center randomized control trial comparing restrictive versus liberal. Good population, almost 1,500 people, more than 1,500 people actually. So in restrictive, half numbers, and then suspected or confirmed infection, and somebody with systolic blood pressure less than 100 after leaving 1 liter fluid were kept there, and vasopressor was the primary therapy, and some rescue fluid was also given. On the other limb, liberal therapy, initial 2 liters, and then rescue vasopressors as needed. As you can see, the difference between the median fluid was 1.2 in restrictive, and the liberal fluid group had 3,400 fluid. So, and then look at the difference between vasopressors, more vasopressors obviously in a restrictive, because that's what the main step therapy there. And then talking about key outcomes, the outcome was death from any cause before discharge home by day 90. And what they found was no statistically significant difference in 90-day mortality between restrictive and liberal fluid strategies. The secondary endpoint, like ventilator-free days, ICU, hospital length of stay, organ support days, also showed no meaningful advantage for either strategy. So this trial where we did a typical emergency department presentation of sepsis-induced hypotension after 1 to 3 liters of a crystal void. It was looking at whether vasopressors or fluid to be given, and there was no statistically significant between those two. So implication of Clover's trial. So bottom line is either strategy is reasonable. Early restrictive with vasopressors are safe but not superior. But I think that's a reasonable practice in people with reserve cardiac function, somebody with the CKD, with advanced CKD, like hemodialysis people, or somebody who at risk of for pulmonary edema. And then there is no benefit from aggressive fluid loading in all. So one size does not fit all. So it's probably the time to go away from 30 cc per kg of fluid challenge. Some people they might need less, some people they tolerate more. And then strategy should not be infusion. The strategy should be perfusion for first. So whatever tool fits, whether it's vasopressors or whether it's a fluid, basically you do that. Fluid if fluid responsive, vasopressor if vasodilated. And then so basically it confirmed Goldilocks approach in sepsis fluid. So combined with classic phrase process arise promise analysis, moderate volume plus early vasopressor is safe and effective as large volume resuscitation. So that was the take-home message from this global trial. So let's talk about summary of sepsis. So no survival benefit to liberal fluid management, Glober classic early goal directed trials, no mortality advantage to giving large volume crystalline resuscitation, early vasopressor is safe. Glober showed that early norepinephrine is reasonable, it's not harmful. Avoid fluid overload, classic strongly supports minimizing ongoing fluid once early resuscitation is done, and then use of dynamic parameters, not the static one. You can use different measures including leg raising or ultrasound stroke volume change rather than just giving fluid blindly. And then balanced crystalloid are preferred based upon smart and salted trial which showed that there are better renal outcomes with renal ringer lactate or plasma light compared to saline. So, and then SEP1 bundle recommendation 30 ml per kg probably needs modernization. One suit does not fit all. In evidence support personalized but not the mandatory fluid volumes. Let's talk about how much to give. So before talking about how much to give, let's ask ourselves, do we really need to give IV fluid? Answer is no. When your patient is able to eat or drink by mouth, there should not be reason for you to put them on IV fluid, unless you are trying to flush their system, which you tend to typically do in a patient with rhabdomyolysis. Or let's say if your patient is NPO for some procedures, in that's a reasonable indication to give IV fluid. So how much to give is determined by how much deficit they have. And if you look at this table, if somebody has lost more than 10% volume, they tend to be orthostatic, they tend to have a tachycardia, and if somebody lost more than 15% volume, they tend to be hypotensive. So that is going to help you to determine how much is the deficit. And in terms of maintenance fluid, you are going to go by formula 4-to-1. For first 10 kilogram, you're going to give 4 ml per kg per hour. Second 10 kilogram, you're going to give 2 ml per kg per hour, and the rest, anything above 20 kilogram, you're going to give 1 ml per kg per hour. So that's how you're going to calculate maintenance fluid. For a 70 kilogram person, you're going to give 40 plus 20 plus 50, so which is going to be 880 ml in 8 hours. All right. Like we just talked about, how much to give is determined by deficit. How fast you are going to give is determined by heart function. Remember, two population, congestive heart failure, especially those people with EF less than 40, you don't want to give them too much. And also CKD people who is on dialysis. Those people, you got to be cautious in terms of total volume you are infusing. In sepsis, they have vasodilatation. The size of tank has increased because of the vasodilatation. So you need to fill that in. How much to fill it in? 30 cc per kg is has been historically true, which has been contradicted by very recent randomized control trial. Whatever works, somewhere around 30 cc per kg is the amount to give. Um, how fast is determined by underlying cardiac conditions. Maintenance fluid, for most part, 60 cc per hour is kind of maintenance fluid. 1 cc per kg per hour is kind of um, grossly. And then generous hydration is somebody who is getting 1.5 cc per kg per hour, somewhere around 100 cc per hour. And intense hydration is something like 250 cc per hour. You tend to do classically with severe rhabdomyolysis, severe acute pancreatitis, or diabetic ketoacidosis. Again, remember, severe rhabdomyolysis in a patient with congestive heart failure is treated differently. You've got to back down on the rate of infusion, also the amount of volume that you're going to infuse. So let's talk about vomiting. What is going to happen? So you're going to your patient is going to lose hydrogen, chloride, some sodium, some water, and some potassium. If they vomit too much, there will be a decrease in blood volume, decreased renal perfusion, results in the activation of renin-angiotensin system, resulting in formation of aldosterone. What aldosterone do? It causes absorption of sodium and water, and you lose hydrogen ion potassium. So remember that patient just vomited hydrogen ion and just vomited potassium. Now he's going to pee more hydrogen ion and more potassium. So this metabolic alkalosis which started, and then hypokalemia which started with the vomiting. It started with the vomiting, but it is maintained by kidney. So, and that maintenance is dependent on that hypovolemic state that patient has been through. So that's why first thing you want to do to decrease the renal loss of potassium is to give isotonic fluid. It doesn't matter whether you give 0.9 normal saline or ringer lactate, that renal loss of hydrogen ion and potassium is going to stop if you expand the volume. So but what happens when you give ringer lactate to these people with vomiting? They are already alkalotic, and then when you give ringer lactate, that lactate goes to the liver and changes into bicarbonate, results in overshoot alkalosis. So you don't want to really do that. They are already alkalotic. You don't want to overdo that alkalosis. So for these people who are alkalotic, the best maintenance fluid is going to be zero point 0.9 normal saline with 20 of KCl. So remember, not all vomiting are same. Some vomiting is induced by ketosis. Classical example is hyperemesis gravidarum. So those people, they have a change in metabolism. They don't have a glucose, and the metabolism has switched to fat metabolism, resulting in ketosis. So what do you want to do to break that ketosis? You would like to give them a fluid containing D5. So the best maintenance fluid for somebody who has a vomiting is going to be D5.9 with a 20 of KCl. So that is going to be the best fluid for these people who vomit. So let's talk about diarrhea. What happens during diarrhea? So patient loses bicarbonate, sodium, some water, and potassium. So looking at the history of ringer lactate, if you look at the composition of ringer lactate, it closely mimics a cholera stool. If you look at the sodium in cholera stool and ringer lactate, both of them have the same number of sodium. So when the scientists designed this fluid, and they couldn't really give 20 milliequivalent of potassium because that's supraphysiological. So that's why they make that dose physiological, and then to maintain the electrical neutrality, they took a little bit in chloride and bicarbonate. So basically, ringer lactate was designed to treat diarrhea. So, and what happens that lactate in the ringer lactate goes to the liver in a person with a normal liver and changes into bicarbonate. So any loss of bicarbonate will be replenished by that lactate component of ringer lactate. So talking about pancreatitis, again, ringer lactate is a fluid of choice. Why? Um, Pancreatic fluid tends to be rich in bicarbonate. If somebody has a pseudocyst or big pseudocyst, they tend to lose that bicarbonate rich fluid into that pseudocyst. So to replenish that loss of bicarbonate, you are going to use ringer lactate, which ultimately changes into bicarbonate in a person with a normal liver. So how much to give in acute pancreatitis depends upon the type of pancreatitis. So this randomized controlled trial was published in 2017. What they found was early aggressive hydration hastens the clinical improvement in acute mild pancreatitis. So they were looking at 60 patients without SIRS or organ failure, and they were randomized within 4 hours, and they were treating with the two different kind of fluid um, plan. So the aggressive limb included 20 ml per kg of bolus, followed by 3 ml per kg per hour. Half the amount was given in standard group, and then patients were assessed at 12-hour intervals. And they were looking at hematocrit, BUN, and creatinine, and also the symptom, which was pain. So if hematocrit, BUN, or creatinine increased, um, patients were given aggressive hydration, and then uh, otherwise they were continued on 1.5 ml per kg per hour, which was standard. So what they found was the primary endpoint was clinical improvement within 36 hours. It was defined as decrease in hematocrit, BUN, or creatinine, and also the improved pain. And so they found that early aggressive IV hydration with ringer lactate hastens the clinical improvement in mild acute pancreatitis. So what are you going to do with moderate and severe pancreatitis? So there was a study published in 2022. It was published in NEJM. It was a randomized controlled trial. The name of trial was Waterfall Trial. They were looking at efficacy or safety of aggressive fluid resuscitation versus moderate fluid resuscitation in acute pancreatitis. They diagnosed people with pancreatitis based upon modified Atlanta criteria. 249 patients were included. Almost half of them were in aggressive and half of them were in moderate lame. So when they compared both those lames, after that randomization, they were giving either aggressive or moderate. In aggressive, they gave 20 ml per kg, followed by 3 ml per kg per hour. Half the amount was given in the moderate limb. And every 3 hours, at 3 hours, they were doing safety check whether somebody is getting fluid overloaded or not. And at 12, 24, 48, and 72 hours, they were doing goal-directed therapy checkpoints. So what they found, regardless of hydration, the development of moderate or severe pancreatitis was similar in both the limbs. And the secondary outcome, which was mainly fluid overload, the use of aggressive fluid resuscitation actually resulted in a higher risk of volume overload. But there was no disease-specific benefit. So this was kind of very important trial to guide us about fluid management, not to overdo fluid in management of acute pancreatitis. So let's talk about sickle cell disease. So the size of RBC and the capillary, they are almost the same size. So whenever RBC is traveling through capillary, it has to squeeze through. So that requires the hemoglobin to be really flexible. So what happens in sickle cell disease is, substitution of glutamic acid with a valine in hemoglobin chain results in a loss of that property, loss of that elasticity. And when that happens, the RBC can no longer is malleable. and it results in stagnation and clogging of the arteries. So to reverse that pathophysiologic process, what you are going to do is, one of the reason why you had that decreased solubility is because of the dehydration. So you would like to give some fluid. So which fluid to give? So fluid is important. It doesn't really matter whether you keep 0.9 or 0.45, but I prefer 0.45 for good reasons. So half normal saline and that hypertonic fluid tends to go inside the cell and provide better hydration intracellularly, and that's exactly what you would like to do in a patient with sickle cell disease. But remember, hydration is important, not the type of fluid. But remember, to avoid excessive fluid, don't just keep on giving that fluid forever. What happens is these people with the sickle cell, they get a lot of transfusion throughout their life, and then if you give more blood, it is all iron. Iron goes and binds to the parenchymatous organ. It goes to the pancreas, causes bronze diabetes, goes to the liver, causes cirrhosis, goes to the heart, causes cardiomyopathy. So we cannot just rely on that heart to bear the pressure of all this fluid. So don't overdo IV hydration. Actually, if you give too much fluid, actually it expands the interstitium and results in a factor for pain itself. So typically what I tend to do, I tend to give them fluid for first 8 to 12 hours and kind of stop at that point. I think that's the best strategy. And in addition to that, I tend to give oxygen. So, regardless of the fact that they have a SpO2 or pulse ox more than 95. So this is one of the few conditions where you are going to give oxygen despite the fact that pulse ox is more than 95. So in pain management and looking for infection and treating infection. Remember, these people, they have autosplenectomy by the age of 5, so they are at risk of infection by capsulated organisms. So the summary is balanced fluid like ringer lactate is considered now fluid of choice, both in perioperative and critical care settings. So in sepsis, 30 cc per kilogram of fluid is first to give, and try albumin prior to use of vasopressors. Ringer lactate is a fluid of choice, needs to be started early. Early vasopressors, specifically in people with congestive heart failure or somebody with CKD, advanced CKD. About 30 cc per kilogram, though it is not ideal yardstick, but still it will provide some good number for us to guide about volume management, because historically fluid management has been the mainstay, and it has been proven time and again it is the mainstay of sepsis management in addition to antibiotics and source control. In people with CNS disease, avoid ringer lactate. 0.9 normal saline is a fluid of choice. In ringer lactate is preferred for acute pancreatitis as well. Avoid excessive hydration in severe pancreatitis. Fluid important is important for management of sickle cell disease, but don't overdo it. So this concludes my presentation. Any question and queries, feel free to reach out to me in my email, and thank you so much for your time.